I'll pass over to yourself, Deepak, to talk about pain reframed healing through lifestyle and nutrition. Thank you.
Well, thank you so much to Chris and all the team at the North British Pain Association for having me on this afternoon. A lot of my topic today is going to be focusing sort of a broad overview of lifestyle medicine-based approaches, but in particular, I'll be focusing on nutrition. And it seems a little ironical that I've been given the post-lunch slot. So I hope I don't put any of you to sleep, and I hope you'll find this information a little reflective of your nutritional choices as well at lunchtime just now. For full disclaimer, I've had a sandwich which doesn't really come top on what should be good nutrition, but there you go, that is life. So if you can just let me know, Chris or one of the team, that I've gone on to slideshow mode.
You are. That's it. Perfect.
Perfect. Brilliant. Well, thank you. Right. So part of my, as I said, the main topic is going to be looking at nutritional neurobiology and why I think that's a very tangible new frontier for pain management, especially for clinicians in secondary care, and why that I think is a very good link between what we need to be doing with our primary care colleagues. My career itself has changed in some of the way that I have wanted to now walk the walk instead of just doing talk the talk. So after 14 years in secondary care at the Royal Berks Hospital, last year I moved into primary care, and presently my role is as a director of lifestyle medicine for a primary care network in Berkshire. Apart from that, I have a few other roles. I do have a few other declarations of interest. I think the most relevant one for this talk is going to be the one on the top left as a trustee of the British Society of Lifestyle Medicine. I like talking about pain science. I am very passionate about spreading that information about pain science education in the broadest sense, not just about the neuroscience itself, but actually on every aspect that can be covered. And so, therefore, I have some roles with the e-pain and as well as a clinician YouTube content creator. But ultimately, there has been a big wave. And for those of you who are not aware, there is this society called the British Society of Lifestyle Medicine. It's one of maybe about 80 to 100 such lifestyle medicine societies that have come up across the world. It's the fastest growing medical specialty of the last 10 years. Every medical school in the UK right now has got a medical student-led lifestyle medicine society, as far as I'm aware, and they are quite active because there is that complete realization that long-term conditions of any kind, not just chronic pain, but metabolic issues, asthma, obesity, everything has got a lot to do with some of the choices we make. And I don't mean lifestyle in the pejorative, it's all a single person's problem. The British Society of Lifestyle Medicine completely understands that being aware of the social determinants of health as a first step is extremely important, because some people just cannot be in a situation because their ecosystem doesn't allow them the affordance to take on these pillars. But where possible, if you can bring evidence base into these six pillars, then you are going to make a substantial difference in the outcome and the well-being and health of patients who have long-term conditions. And if you look at this, all of these are things that we as pain clinicians have been doing, especially our physiotherapy colleagues, our psychology colleagues, our occupational therapy colleagues have been doing this for many years in some way or the other. The one probable aspect that hasn't been done effectively and probably needs to now be now needs to be done is essentially nutrition. And to me, when I wrote my book as well, when I came across the principles of lifestyle medicine and I qualified as a lifestyle medicine physician at sort of 2020 when the pandemic was ongoing, I found this natural synergy between my role as a pain physician, where I was very proficient in knowing about medications, doing any interventions, getting to any particular group of nerves, as long as I had a good long needle in my hand and a C-arm machine. It is also the realization that actually there is enough and decent quality evidence in all the other approaches, the neuroscience, the diet, the sleep, the exercise, as well as mind-body techniques. The question that left to me was actually how do we make the other five equally easy to access, fun to do, and actually sticky in some way? And that's been the journey that I think we all need to be on, and certainly the journey I've taken on in terms of saying how do we get this approach in a more uniform, scalable manner. And in particular, nutrition, I think, is a very tangible option to consider and offer to our patients as we realize that there is a limit to what medications can do and how successful they can be and what our choices are, knowing what we now know about them. And interventions, given the scale of the evidence that's there and the commissioning problems that we face in our neck of the woods, we do really need to be thinking about offering nutrition as a very tangible target. Now, I know I'm not a nutritionist, but I've done my share to kind of educate myself and then create the resources to actually improve on that education. For those of you who are also British Pain Society members, I look forward to seeing you all on June 3rd, where we've got the opportunity to do a whole day workshop on lifestyle medicine with about a couple of hours on nutrition itself. And at that time, I'm going to be having a dietitian or nutritionist also talking about some of our research in Leeds and the work that we're doing there. But I think nutrition is a central component of a whole person approach to pain management. So in this talk there, I'm going to be focusing a little bit on the why, just a broad overview of the what and the how, the assessment. And I'm just going to leave you with some resources and some signposting on what is the minimum data set and information that we all healthcare professionals can give safely to our patients without being worried about breaching the scope of our practice or the remit of what we need to do. And nutrition in chronic pain is not new. In the last 10 years, there have been more than 250 articles in different journals in the popular press looking at this link between chronic pain, the gut microbiome, and how we look after our microbiome. This is from Nature itself as of September last year, freely accessible. I got this on link on the net there, so I urge you to check it out. But ultimately, I'll paraphrase an excellent statement by John Cryan, one of the foremost gut scientists from Northern Ireland. And he actually said, whatever happens in Vegas doesn't stay there. And that's very important to know because we're realizing that the vagus is not just the wandering nerve that we try to block in a stellate ganglion block as part of the overall process and accidentally happens. We now know that the vagus is a true link to the brain and the gut and the endocrine axis. If you think of it as a bidirectional highway, you've got to imagine that it's got 6 lanes that actually take the information from the gut to the brain, but there's only about 2 or 3 lanes that actually bring the information from the brain back to the gut. So the brain actually is getting a whole lot of interoceptive information from the vagus, and that really what is making our brain and the nervous system a true supercomputer, the vagus and the information that is being processed and sent through it. Apart from that, we know that the gut in itself is also the area for the largest immune organ, as it were. In many popular words, you hear about it being the second brain. But what's something I realized recently is that more than 90% of the serotonin, things that you think are very much the mood chemical, is formed in the gut and taken to the brain. More than 50% of the dopamine, your drive chemical, is formed and made in the gut and taken to the brain. If you were to open it up and sort of peel it and lay it out, it is the largest sensory organ with a surface area that's equivalent to a basketball court. So imagine that every day inside of you right now. The Human Microbiome Project that came out from the US after the Human Genome Project effectively concluded that if you took all the genes from all the microbiome microorganisms that are there and combine it with the human genes, that is what is called as a hologenome. And there is a constant, huge, intense amount of interactions that keep occurring between the genetic material in the microbiome, in the microorganisms, and our genes. And these genome interactions are actually the norm. That is what makes us much more human, much more complex. And given that we as a species have only got 23,000 genes, whereas the maize plant has got 28 or 30,000 genes, you really got to think that these microorganisms are adding so much more to the diversity of our thought, of our thinking, and of what makes us human. Now, there is some other newer facts that has come across broadly in the space of neurodevelopment as well as in sort of brain development as such. We know that it plays a critical role in BDNF, so the brain-derived nerve factor. There's been studies shown both in animal and to a certain extent, I think some human, but that when you have elevated stress response in the young, there are multiple changes in the neural circuits throughout the brain itself. Potentially, that vulnerability of psychology, as we can see later in adulthood, may be a reflection of this. There's also the potential that when the number of bacteria are all reduced, that has a change in neurodevelopment as well, particularly lactobacillus and bifidobacteria. There is data to show that if you have mice with absolutely no microbiome at all, so-called the germ-free mice, they actually have less sensitivity to pain and less memory or less neuronal changes in the hippocampus. So certainly there is some contribution of the microbiome genes to the development of the nociceptive processing circuits as well as the hippocampal circuits there. Ultimately, these might be at a level of neural circuit formation, or it might be even more granular at the level of gene expression, so epigenetic changes. And there are certainly data and associations that are saying that even mental health disorders like autism or schizophrenia or even anxiety and depression may have this element of microbiome related involvement. When you narrow it down to actually chronic pain, there are studies coming through, and I'll go to it later. But in the last couple of months, I would urge you, this is a free access article that expands this whole thing of all kinds of neurodegenerative disorders, not just the autism, schizophrenia that I mentioned in the previous slide, but this particular work by O'Riordan actually talks about so many other conditions that in general medical literature we would not think of as being linked together, but the gut microbiome is starting to link to them all together. What else does the microbiota do? We now understand that they are able to modulate the amount of intestinal pathogens. They're responsible for homeostasis. They are primarily responsible for the fermentation of the dietary fiber. Indeed, fiber actually feeds them than the other way around. And they probably are responsible for a lot of the drug processing and metabolism, and how we could explain why certain times antibiotics don't work in some people, and at different times the same antibiotic may have different expressions in us itself. Ultimately, we think that they are creating a kind of talk or a communication that they set up with our immune system on the other side of the single cell gut barrier. And that is resulting in a lot of neurotransmitter and cytokine formation, release, and signaling. When you come to chronic pain, this whole component of biodiversity alteration, what's called as dysbiosis or altered gut function, can change the lining of the intestine, can change the immune system expression, both the innate and the adaptive immune system. And this combination of dysbiosis could potentially lead to what is popularly called as leaky gut, but basically a separation in the gap junctions of the intestinal villi. And then when you combine it with the fact that when people have visceral fat acts like an inflammatory organ, releasing inflammatory cytokines called adipokines, and these are a potent combination. All of these things will end up causing changes and promoting chronic pain. This has now been studied. This study came out by Goodman, which was a systematic review and a meta-analysis from last year. They looked at about 4 databases, 6,000 articles and above, with their inclusion and exclusion criteria. They selected final 21 articles, of which 19 of them studied chronic primary pain, 2 of them studied chronic secondary pain. And what they noticed was that 3 particular organisms, which are here, post lunch, if I can spell them right. I think that's points for me. Lactospiraceae, Faecalibacterium, and Odoribacter. All of these 3 species are reduced in abundance. Now, these 3 bacterial species are hugely responsible for the production of what's called short chain fatty acids. And that is something that is shown to now be very relevant in cardiac disease and cardiovascular disease, as well as in pain as well. Now, in this particular systematic review and meta-analysis, they had 2 particular indices that they are looking at when you are doing microbiome research. It's something I'm still not familiar with, but what they did notice was that these particular 2 indices, the alpha diversity and the Shannon index, one measures the diversity in the environment. The Shannon index is particularly for bacterial species. Both these indices are markedly reduced, indicating that biodiversity is affected significantly, has an association in all these chronic pain patients. What about those 3 bacterial species? When those 3 bacterial species are reduced, the amount of short chain fatty acids are reduced. When those short chain fatty acids are reduced, they have a normal role in changing the introduction and the immune system within the intestinal epithelial cells. If they are not present in adequate amount, it activates a certain set of immune chemicals and cytokines within the intestinal cells, and that on the other side ends up resulting in a transduction, and an inflammatory immune response gets set up, and that is something that they are proposing as a possible change that's happening at the basolateral, the blood side, rather than the apical side of the villi, which is the luminal side. And this, alongside this separation of the gap junction, which might occur. So when you have a reduced diversity of the good bacteria or the good microorganisms, there is a relative overproliferation of the relatively harmful microorganisms, and they release a very potent metabolite called lipopolysaccharide. And that lipopolysaccharide damages the mucin layer that lies on top of the intestinal villi, and that can be responsible for, once the mucin layer is gone, the junctions don't have anything to protect them, and that starts to get leaky. The lipopolysaccharide starts to make further way along the junctions to the blood side, aggravating the immune response. What are the other things apart from the diversity reduction? What else can contribute to diversity reduction in this way of these bacteria? It is processed foods. It is all the kind of food that we have here. It's also certain drugs like statins, anti-inflammatories, unfortunately opioids. And that is something we as pain clinicians have to be aware that many of the drugs, apart from their usual problems, we now know that they actually reduce the diversity when taken in long term. And that can be one of the contributors to a state of chronic oxidative stress. There are a few other key metabolites that have been identified, and that is essentially these ones, the short chain fatty acids, lipopolysaccharides, secondary bile acid, a few other tryptophan derived metabolites. And all of these have shown to be modulating the gut brain axis by regulating the immune response, and can cause neuroinflammation and impact on the nociceptive signaling pathways. Ultimately, I present a sort of overview in my book, which essentially says that if you start off with a poor nutritional strategy, which consists of all these kind of foods on the left side, you are going to change the biodiversity. You're going to cause peripheral inflammation within the vagus that's going to activate the immune system as well as spread to the central nervous system. And in this brain and in the central nervous system, it's going to activate the microglia, the astrocytes, which will cause neuronal damage, sort of collateral damage, and synaptic dysregulation, all of which leads to a low-grade neuroinflammation state. Sometimes in animal studies called as central sensitization, but that is something that has been noted there. What actually happens when you say astrocytes or microglia are activated? Well, microglia, the resting microglia, have got this particular set of surveillance cameras called the toll-like receptors. And when you have these patterns that change and affect the TLRs, the surveillance camera goes off. Now, depending on what it has been coded for, these surveillance cameras activate the resting microglia into one or two of the two states. Either they become M1 microglia, in which case they are pro-inflammatory, or they can become M2 microglia, which is anti-inflammatory. And this is a very dynamic response. So if you can change the environment, if you can change the ecosystem, if you can change the ecosystem of the local environment as well as at a macro level, the person's environment, you could move the microglia from an anti-inflammatory, from a pro-inflammatory to an anti-inflammatory state. And that is the promise of what actually happens at the underlying place of neuroplasticity, is probably this change of the microglia to something that promotes healing, promotes recovery, and is anti-inflammatory. Combine with this particular growing field and understanding of insulin resistance and the concept of peripheral and central insulin resistance. I won't go into it too much today, but essentially we are realizing that insulin resistance is not just a metabolic obesity and diabetes related issue. It's now shown to be a major factor in many central nervous system, neurodegenerative, and mental health disorders, like all of this resulted above. Effectively, many authors and researchers are now looking at this feedback between the mental and the metabolic state, which can be contributory and plays into many parts. So, in that context, when you look at nutrition and you know that our patients with chronic pain also have 1 to 2 to 3 coexisting metabolic conditions very often, coexisting mental health disorders very often, I think this is a prime opportunity to actually bring in some strategy that's already being used in those groups of people and do it more actively in our group of patients as well. Because that same component of oxidative stress is going to be responsible for this third category of pain called nociplastic pain. And that I think is going to present often as chronic pain in a lot of our patients. Just to reiterate, we now know that what is considered as nociplastic pain is a situation where most of our medications and interventions do not work. And in that situation, this kind of nociplastic pain, I at least tend to think, for the purposes of patient education and healthcare professional education, it's somewhat synonymous with the concept of chronic primary pain. And I accept that central sensitization is still a debatable entity in humans. It is at least roughly equivalent to that as far as education is concerned. When you look at, therefore, nutrition, what the studies and the data up to now, I think we still are quite far away from proving causation, but there is a lot of small studies with many mainly positive results as long as you take the bias and the small studies and all those biases into account. And Catherine Brain has done a huge amount of work in this space here. Her most recent systematic review does talk about at least 29 good to fair studies, but that's kind of balanced by actually at the same time 29 methodologically poor studies. But we need to really do more research in this front. However, she still feels that, and I do agree with her, that we have probably enough to actually say that we can consider nutrition as one of the central pillars of chronic pain management. So, with that kind of background in place, I want to just give you some pointers of what might be some good strategies to assess and what might be the simple things you can do in terms of supporting our patients in chronic pain, in secondary care, and probably in community land. I think these recommendations are quite simple. I mean, these are things that all of us should be able to do. And my hope through all the work that I'm doing is to at least just ensure that we have a common hymn sheet when we speak to our patients and feel confident in saying that if they can improve their dietary quality, consume more fruit and veg, a generally plant-based diet or a predominant plant-based diet with appropriate amount of animal nutrition, reduce their alcohol and coffee content there, I think that is a good start. There will always be a place for more targeted assessment and support from our psychology colleagues for those with disordered eating. But the simple top tips are reducing the pro-inflammatory, adding in anti-inflammatory stuff, ensuring good hydration, looking at supplements and probiotics, etc., and then doing the concept of what's called intermittent fasting. In this space, I would really encourage this particular article by O'Riordan, where they talk about this really complex ecosystem that's coming up now with probiotics, prebiotics, symbiotics, postbiotics, any kind of adjective that they can apply to biotics. They're trying to do it now. But when you combine it with a whole food diet along with lifestyle, there is a huge improvement in many health conditions. This is a simple free work that's come from Elma et al. There's some references for you at the end that I will give, but this is a very nice thing that you can just print out, give it to your patients, help them discuss about simple ways, practical ways they can just start making some changes in their nutrition. And then, of course, depending on your confidence, you can talk about a few antioxidants or polyphenols, your own biases and your own knowledge you can bring into here. I write some in my book as well for suggestion, but please do feel free to check out O'Riordan's article to take that. I'll end with this last bit about intermittent fasting because I think it's got a big role to play in terms of dampening the microglia, changing it from the pro-inflammatory to the anti-inflammatory state, and also working in restoring circadian rhythms. So I think intermittent fasting has got a big role to play in supporting our chronic pain patients. And I think we can start with very simple steps, 10 to 12 hours to start with. The aim is to get to 16, 18 hours if possible. Gradually escalating the time is a doable option. And actually, sometimes when you combine it, do it as friends, have someone accountable, have some family members supporting and considering the social aspect of food, I think there's a huge chance in making this work. My final thoughts about any kind of anti-inflammatory diets. I think there's a huge thing, and I'm not going to go into deciding whether you want to go for a carnivore or a ketogenic, and there are rules and regulations and times for one of those specific kind. But I think if you can get cultural congruence, if you can get rapport, and if you can make it as close to the patient's understanding, then I think that's important. So implementation is more key than getting a particular kind of diet. There's obviously the understanding of what motivation they have to make that change, what is their capability, and what opportunity they have. So I think that's all very important in understanding how you put these dietary restrictions into practice and finding out where they are in the readiness to change or taking on nutrition has a strategy when you're trying to move them away from medications or interventions. That's a completely separate discussion which both you and the patient will need to have. My view is that when people are still not ready, all you can do is signpost them to a variety of resources. And at this stage here, I would give you the suggestions of websites like the Partnering Pain videos, the Live Well with Pain nutrition module that they have now, the Rethinking Pain site, a little bit of plug for my book there. But I think once they are ready, you can bring this information in our pain management groups and use that as a support. And ideally, they will need some peer support, whether that's through pain cafes, whether that's in the primary care or in community or in secondary care. I think this is still an evolving field. And how do you provide maintenance and open access to keep the support ongoing? I think if you can combine this framework of pain science education along with motivation interviewing techniques, that to me feels like the best approach of coaching along with the model of behavior change. These are some videos that I often suggest, which are available on various sites and the Microbiome Medics podcast. For those of you who want to dive deeper into microbiome, please do go into there. I did some work with them last year as well. Let me see if I can just move the slides up there. Okay. And this is the final site that's come from Rethinking Pain, the Leeds-based group. Excellent work by them in terms of multiple languages, implements that people can use, and small bite-sized videos around nutrition and pain. And the same is with the Live Well with Pain group as well. So in summary, the microbiome plays a very integral part in central sensitization. I think if we can feel comfortable about talking about tangible options about nutrition, especially nociplastic and chronic primary pain, I think that's a very important step that we can offer our patients when we try to move them away from traditional biomedical approaches. I'm sure it's a part of the whole person approach there. And I think if you can combine it alongside the other ways of coaching, motivational interviewing, and pain science education, we can present a tangible target. And in some ways, if this is something that can be done in secondary care, it will very nicely chime in with what our primary care colleagues are doing. And ultimately, that integration is important. If patients hear one kind of nutritional advice for their diabetes or for the mental health, and they hear either nothing or something different for their chronic pain, they are not going to do anything at all. So the aim is to see if you can have that collaboration with your primary care colleagues to see if you can actually piggyback on what they're already doing in primary or community care, or ensure that what we do in secondary care aligns with what's happening. And that's where I think the work of BSLM is quite useful, because you can get that kind of overall simple evidence base. Implementation is key. There are some references here, and probably if you just wanted to, I appreciate this is a bit of a whistle stop tour, but if you want to know a little bit more, please consider attending the BPS ASM workshop on June 3rd. And if you wanted to just have a bit of a careful reading, for those of you on the physios and are part of the MSK MAG group, I wrote an article on this in the March edition. So you're welcome to go for that if you're subscribed to MSK MAG as well. Thank you for listening to me. I hope I didn't left you sort of hungry for more, pardon the pun, and email me on here if you want to speak to me separately. Open for questions. Chris and team, do I have time for questions?
We
Yes,
do.
Brilliant.
I've got a few. Thank you so much for that. That was great, and great to really thought-provoking, and great to, especially those top tips that we can all use within our own scope of practice as well, is really, really helpful. We do have a few questions. So we've got one from the Q&A from Anna. What are the evidence benefits of intermittent fasting on health in general and pain in particular?
So pain in particular, there isn't much that I'm aware of. When I was preparing for, I will have another check of the literature when I'm sort of getting ready for the BPS ASM. But intermittent fasting in pain is still a very emergent and nascent field. But overall health and well-being, I think one of the big things that came through, and one of the Nobel Prize winning from Japan as well, was this whole concept that when you go beyond 16 or 18 hours, and you can actually go up to 22 hours, you're able to bring about conditions that are conducive for autophagy, which means you're giving the body the time to do its own cleanup. And effectively, that part has been fairly well proven to say that if you can give your gut that bit of downtime, and you give at least 9 to 12 hours, then you're effectively allowing for some of the self-cleaning mechanisms, not just in the gut, but that also spreads to the immune system. And that is what has shown to be responsible for changing that. Now, with regards to metabolic syndrome, certainly as part of the low carbohydrate approach to managing diabetes, reversing insulin resistance, restoring insulin sensitivity, and actually improving metabolic health, fasting has become a very critical component of this overall low carbohydrate approach to metabolic health management. So in that space, we have got a lot of stories, and I have a number of patients who have told me that that kind of fasting approach really changes their well-being, has improved their metabolic health, allowing for weight loss, weight reduction, and general feeling of well-being.
Mm. Yeah. Oh, Claire, your mic is off.
Oh, thank you. We have another question here from someone that's remained anonymous. Patients can be really focused on weight reduction to support pain reduction, and with more wider use of weight reduction injections and tablets, how does that impact on the gut microbiome? And do we have any evidence of that as yet?
Fantastic question there. And it is, that is going to be one of the challenges that we at the BSLM have. So we've released, so now I'm now wearing the hat of the trustee and part of the BSLM. We've released a policy statement and a position statement saying that the UK government's decision to sort of allow for primary care prescription of weight loss injections starting from this month and next month by community pharmacies and pharmacists themselves needs to be very firmly wrapped up in a whole person lifestyle approach. So we shouldn't be just giving the injections alone, and we shouldn't be doing that alone. We should be combining it with appropriate advice around what kind of nutrition we should be having, what kind of foods we should be eating, because there's data coming out that people are right now paying for these weight loss injections privately. They already have poor nutrition to start with. They think that by taking these injections, eating less because now they have less money because they think they can lose weight with the injections and that's all they need to do. So they eat the same kind of crappy food in smaller quantities, but with injections. And so we are getting cases of osteopenia, we're getting cases of kwashiorkor with significant vitamin deficiencies, and there is a reduction in muscle mass. And not to say there's now evidence that up to 1/5 of patients who have been on these weight loss injections, if they don't have a good conditioning protocol or advice in place, they're going to get chronic pain or new onset so-called musculoskeletal pain that is probably a side effect of these weight loss injections. So I think this is a field that could make us more busy, but all the more reason that when they now come to us and they can identify that these things started within a month or two of them being on weight loss injections, then we need to be also equally uh, part of singing the total hymn sheet. I'm very much in favor of creating an ecosystem wherein people keep hearing the same message from different people, so they consider change. So if they are going to come to the pain clinic, I think it's critical amongst us as healthcare professionals to reinforce the message that they need to be eating healthy and to be having a whole food diet alongside their weight loss injections, because that could again be contributory to nociplastic pain if they are not taking the right precautions.
Thank you. And I wonder, just given the complexity of it almost, and you've given some examples of how we could use that within our different scopes of practice of our different kind of professions, do you know of any examples of dietitians being included in MDT for pain management, or do you think this is important for the kind of wider MDT going forward?
I think it should be so. For example, in Leeds Beckett, Ursula Philpott, who is coming with us to do the talk in the BPS, is being really at the forefront of working with the Bradford and Leeds community pain team. And she's actually advised and created all the sort of supported the creation of the Rethinking Pain videos, taking into account there. There is suggestion, certainly we've had chats and we are writing up a paper now, and she said that one of the things that chronic pain patients do have, and maybe we need to be doing a quick assessment at least, is to say what is the incidence of disordered eating in our chronic pain patients. So that may need a little bit more targeted support if they are coming to our chronic pain clinics and you just give them advice around fasting and you haven't recognized that they've got a slightly disordered relationship with food, then that's something we should be careful about. So that's something we are going to be talking about. And I would say Ursula Philpott is one person to speak. Down south in the Royal Free, Lucy Ward and me, who are doing this workshop together, she's actually got funding in a community pain clinic to actually get a dietitian in-house for the last 2 years. And they have been doing this kind of food-based pain management program. So a 6-week program where the slight focus is more on how to eat healthy, having weekly plans and suggestions. And some of the work that she's done is feeding into, that is again a wrong pun, but yes, that is just feeding into a having something that comes out from the BPS as a nutrition and pain do's and don'ts of what we would suggest.
Thank you so much. Yeah, and it is so complex. That education is really key, I think, in what is the healthy eating and how to start that.
Absolutely. I know something very simple itself, like, when patients talk about, well, how can I eat healthy? And this is something as a field in the community I'm interested in. I appreciate in a secondary care service that might be difficult to do. But I think one of the things that, for example, Ian Taverner, who suffers from fibromyalgia himself, and he's written a book called Cookfulness. But what he's done is he's been able to just suggest simple things that you can do when you're in pain. And actually, he's got these implements and things that he uses for cooking. So that is something very critical. People with osteoarthritis, with hand and pain, who cannot sit for long, who cannot cook for long, how can they be healthy and how can they be efficient? So sometimes you do have implements as well that you may have to suggest to your patients so that you actually create the ecosystem so that for them making this change feels easy to do, feels doable. And if they've been given all the support and resources to say, here's a shop where you can buy a can opener that actually can make it easy for you. Here's a place where you can get cans that are only 59p as opposed to organic stuff. I think as much of the friction that we can reduce for our patients, that is all going to be part of what makes them transition from saying, I'd rather prefer a £1 50 pizza from the corner shop than taking that extra bit of effort to eat a little healthy.
And as an occupational therapist, I can just plug for us to say that meaningful occupation of being able to create and make your own meals is so important as well. We have 2 minutes. I think Chris has a question as well, if we have just a few minutes left.
Thank you. Great talk as always, Deepak, and thanks for taking the time to join us today. First thing I want to do is on top of your shameless plugs, plug your book a little bit further, particularly the topic on nutrition. I think if anybody's looking to include a presentation on nutrition in a pain management program, I really found yours went through the gears really nice, and there was a really lovely flow to it, and it made the job easy of including this in the pain management programs that I run. So thank you for that. It really saved me an awful lot of legwork. You mentioned about the biotics trend and all the different sort of precursors towards that, and I wrote 2 of them down. I didn't get the third one down, but you said there was 3 particular microbes that were distinctly lacking across a number of different chronic primary pain conditions. Lacnospiraceae, fecal bacteria.
Yeah, I can send the slides too. So it's Faecalibacterium is one fancy name. Lacnospiraceae is another second species, and Odoribacter. So these are the 3 species that this particular study picked up as being reduced in diversity, and because these 3 bacterial species are responsible for a lot of the short chain fatty acid production, they felt that this is an association that could be relevant in this group because ultimately it's an association study. They picked this 21 chronic primary pain studies, and sorry, not 21 studies overall of pain patients, and they looked at to see what is the association there. So I think we have to be mindful of the biases in there. But within that scope of that, they said that these 3 bacterial species seem to be reduced. And because these 3 bacterial species are responsible for these biotics, then short chain fatty acids, then they may be responsible for chronic pain. Now, in relation, I'm making this tenuous connection because I thought that's where you're going with. We do not know, and these 3 species of bacteria are predominantly in the large intestine, which is generally an anaerobic environment. Now, the big thing with a lot of probiotics, which effectively refer to readily available bacteria, are that these are aerobic organisms. As human, as technologically advanced people, we still haven't figured out how to create an anaerobic environment and produce it at a industrial scale to actually have those kind of microorganisms available for sale on our shelves. So all the probiotics in the market right now are essentially aerobic microorganisms that can be industrially manufactured and processed at scale, and that's the probiotic. So we don't have any evidence that probiotics can change pain at all at this time, and they're mostly lactobacillus and bifidobacteria. So that is something worth doing. Prebiotics are interesting because prebiotics are essentially all the foodstuffs that form the fermentable fibers and the probable foods for the large intestinal microorganisms. So that's why prebiotics are useful to have and nice to do. When you combine pre and probiotics together in one marketable product, that's what is called a synbiotic. And when you give synbiotics or prebiotics, there are now the realization that probably it's not them, it's the metabolites that come from these prebiotics and probiotics. That is what is called the postbiotic. So the metabolites that I put in my slide, which is the SCFAs, the tryptophan metabolites, the succinic acid, those are all called postbiotics.
No, that you got exactly where I was going with my question. So thank you for that, Deepak.
Thank you so much for your time, Deepak. That was really interesting, thought-provoking, and great to have you with us today. Thank you.
Thank you so much, Claire.
We have a few minutes for a movement break at the moment, and then we will return at 5 past with Professor Antonia Ligori. And so if you want to take a few minutes just to have a movement break, and then we'll move on swiftly on for the rest of the afternoon. Thank you so much.
Thank you.